we've got idelalisib approved, and we heard studies today presented from duvelisib, the gamma delta inhibitor, as well as a novel delta inhibitor with a TGR 1202 compound. As a class, they seem to have some potential toxicities, but kind of intriguing that we're seeing slightly different toxicity profiles. Of course, there's also the question as to whether or not that's just to do with the fact that many of the patients haven't been followed long enough to see the toxicity profile appear. Again, probably a higher toxicity profile, I think most of us feel with ibrutinib, so an even more strong rationale for thinking that these are classes of agents that you want to have for a defined period of time and not expose patients to very long term.
So, I mean, I would agree with that totally. If we look at idelalisib that's now approved, you know, and it's approved for, I think, CLL as well as ibrutinib, when doctors and patients make a choice, I think generally speaking, they're gonna choose the drug that has fewer side effects. With at least idelalisib and with some of the drugs that are not approved yet, it's felt that there's some class effects on causing transaminitis, on causing diarrhea and late-term actual inflammatory diarrhea. Many people feel, and it's probably correct, that these may be immune-mediated. So I think that we need to learn how to use these drugs. It's certainly possible that if we combine them with steroids, that we may be able to give them more long-term, where they are better tolerated. But I would agree with you totally that if we're going to start to combine them with other drugs, that I think it's going to be especially important to look about limited exposure. There have been attempts to combine idelalisib with a experimental inhibitor of SYK, which is upstream of these pathways, and that resulted in some pretty serious pulmonary toxicity, and that may have been immune-mediated. They've also been combined with lenalidomide, and that resulted in very severe liver toxicity. But in all these cases, they were given as doublets over a more prolonged period of time. And so I actually am an advocate that we really need to think about combining these in kind of short, more like we do chemotherapy, give them for maybe 2 weeks, and then maybe a week, 1 week, 2 weeks, a week off, and give them for a limited period of time, 6 cycles, and then to assess that if combined with other agents, do we get so much synergy that we actually may be able to get patients down in very deep CRs, and then it wouldn't be necessary. It may not be necessary to give more prolonged therapy.
Sure.